Okay, so thanks everyone for coming along today for another one of our showcase sessions. So I think a number of you have been to these before, but just a reminder, they're basically a way in which we twofold sort of purpose. One is to let you know a little bit more about what we get up to in the PenCHORD team outside of HSMA, because HSMA is kind of like the shop window, or I sometimes refer to it as the conservatory, where we invite people in to hear about what we do and get a chance to do some of that stuff themselves. But also, of course, because this is a prime opportunity at the moment for you to be thinking about your projects, your project proposals, which you're going to be submitting by the end of March, 28th of March. So in addition to all of the training, obviously these sort of reports of projects that we've done, both past and present, quite a nice way to sort of inspire you for potential ideas for your own projects within the program. And delighted today to get along my colleague Mike Allen, who's going to be talking about some geographic modelling around the stroke work that you've heard about before Christmas, but actually looking at some of the geographic modelling aspects of this, because particularly you saw on Tuesday when Elliot introduced you to the world of geographic modelling, that there's some fantastic stuff that can be done with this. So a great opportunity to see some of that theory in action today. So without further ado, I'll hand over to Mike.
I'm going to mute myself. Terrific. Thanks, Dan, and thanks for coming along, everybody. So I've sort of titled this "Optimising Conflicting Objectives," because that's often the sort of meat of where we are with a lot of geographic problems that you're trying to solve. And we'll have a look at an example. So we've been working stroke modelling for quite a while. I should say Kerry's actually does most of the hands-on modelling for this. Anna joined us recently, and she's doing some brilliant work on converting times of treatment based on how long it took you to get to a stroke unit into what's the likely level of disability outcome. So, because we're always most interested, if we can get it, to get a sense of how will this affect outcomes. And Martin James is the stroke physician we work with. And this work was very much done in collaboration with NHS England, particularly at the time Tony Rudd was National Clinical Director of Stroke and wanted sort of modelling done at national scale, and also the Stroke Association, who funded quite a bit of the work. So I'm sorry, some of these slides are a bit wordy, but let's talk you through it. So most strokes are caused by a clot in the brain. So about 4 out of 5 are clots. The other ones are bleeds. And if you get the patient to hospital quickly after their stroke, you can try and treat that clot with either breaking it down by injecting something we call thrombolysis in, or an emerging treatment for the biggest, where you've got a clot in a big artery in the brain, is removal of the clot. You sort of guide a mesh up through the arteries and into the brain and remove it that way. But the treatments lose efficacy. They're losing efficacy quickly, because basically when the brain blood supply is stopped, tissue in the brain starts dying immediately, and it will die over the first, say, 6 to 8 hours mostly. So these treatments need to be given quickly, and so you want to get them to a stroke unit quickly. So you want a stroke unit that's not too far away. Here comes the conflicting thing. You can't have every possible hospital everywhere providing this service, because the stroke units have got to be large enough, they've got to have enough admissions that they can have 24/7 expertise available. And so NHS England set the objectives that, first of all, they'd like, if possible, all patients to be within 30 minutes of a stroke unit. But those stroke units should also ordinarily have at least 600 stroke admissions per year. That's the threshold, they thought. You can start to provide 24/7 consultancy cover. You should have 24/7 radiology services as well, because you need to get them in a head scan quickly and see if it's a clot. And if it is, you can treat it. So the question is, we got these NHS England objectives, and they're in the NHS long-term plan as well. Can we achieve this? So at the time we did, so that's just repeating the objective there. The objective's 30 minutes within 30 minutes with the stroke unit, 600 admissions. At the time we did the work, there were 127 stroke units. And we estimated that if everybody went to their closest unit, which is what should normally happen, there's good coverage. 98% of patients were within 30 minutes of an emergency stroke unit. But actually only 62% of patients were attending a unit with at least 600 admissions per year. And overall, 56% of patients were in 30 minutes of a unit with at least 600 admissions per year. And the problems that causes is they don't have sufficient expertise in thrombolysis, and you tend to find, it's just a rule of thumb, the smaller units with fewer stroke admissions use these treatments for stroke, well, particularly thrombolysis is the one that smaller units could do, less than the larger units with more experience. So going to a small unit, you could turn up quickly, but if they don't really have the expertise to administer the treatment, you're less likely to receive it. So one thing we always ask, first of all, is, well, can we just calculate all the combinations? Because that's easy. So in this case, there are, if you sort of say, I want to choose any number of stroke units from 127, there are actually 2 to the power of 127 possible combinations. So that's equivalent to 1.7 times 10 to the 38, or roughly 2 followed by 38 zeros. Now, it's hard to get a grasp on the size of these numbers. So to help us, I put here, the universe is about 5 times 10 to the 17 seconds old. Assuming it's 15 billion years old. So when you look at that, you would actually need to compute a billion combinations, so 10 to the 27 combinations per second for the entire age of the universe to compute all the possibilities. So I think it's a fair assumption we're not going to brute force this type of problem. So it's a general thing. The combinatorial problems, they're fine up until, say, about 20 units, and then they just explode into sort of impossibilities. And I don't know if you come across it, we sometimes call problems by their sort of big O notation, which tells you how much does the problem increase in complexity as you increase the size of the problem. And this is big O 2 to the power of n. So it gives you an idea of whether the problem's going to be solvable or not by computing all possibilities. So, okay, we're not going to compute all possibilities. We want a heuristic. Now, I'm going to talk about a particular type of heuristic, genetic algorithm, which I think Elliot has told you about. And I'll show you a specific kind that we use, which I think they're very nice for this type of problem. But I should say there are other solutions. So you could, the easiest thing to always start off is a greedy algorithm. It sets a baseline. So a greedy algorithm, we would say, okay, I've got this aim that I want the highest proportion of patients that are attending a unit both within 30 minutes and with 600 admissions per year. What's the one stroke unit that would get me the highest percentage? Likely to be in London, I imagine, or another big city, and you pick that and you fix it, and then you say, okay, my objective, if it's 600 admissions and 30 minutes again, is what's the next unit I pick that will increase that proportion as much as it can be. So you go long, you make 120 set, or you stop when you're not improving your objective anymore. You're just doing one thing, you fix it, pick the next one. So they're easy, and it provides a simple baseline. The other ones, hill climbing, that you might hear mentioned, that can be often worth a go because it's a pretty easy type of algorithm to implement. Simulated annealing, actually, that's gone out of fashion, really. You don't hear much about it anymore. Reinforcement learning's the new kid on the block. We've been playing a bit with this, so this is very much the sort of Google DeepMind approach of, can you build intelligent agents to solve these type of problems. I'll talk about genetic algorithms, not the actual basis of genetic algorithms. I'm assuming that Elliot sort of covered the basics, and then you get sort of bespoke heuristics for particular problems. So If you're doing the traveling salesman problems, what's the fastest route around 10 cities, for example? You start off with a random order, and then you go round and you find the best. If you switched the order of just 2 of the cities, which would be the best orders to switch? So you know that these are all heuristics, and heuristics really just mean a method, a recipe, if you like, hunting down good solutions. You're not guaranteed finding the best solution, and you might not know if it's the best solution, even if you found it. So we're using genetic algorithms, but I should say there are other ones available. Now, we've got more than one objective. So I imagine with Elliot, when he covered genetic algorithms, you generally start with, well, there's a single objective you want to meet, but we've got 2. We got to maximize or more than 2 actually, but the key ones are maximizing the number of patients attending a unit with 600 admissions per year, and maximizing the number of patients attending within 30 minutes. And then you could say, actually, really ideally, I want to maximize patients attending both of those, because you could be achieving some of the solutions for admissions in different hospitals to the 30 minutes, and you really want to combine it. But then also the clinicians will come along and say, actually, well, we also want to avoid really large units, because really large units are difficult to administer, to manage. So can you minimize that? And then actually, maybe we can't get everybody to 600 admissions per year, but can we make the smallest unit as big as possible, please? And then we want to minimize the maximum travel time, possibly. It might be okay if we've got a high percentage within 30 minutes, but what if that's at the cost of some people being 120 minutes away? Is that okay or not? And then we want to generally minimize the average time, and mostly we also want to maximize the clinical benefit from thrombolysis. But let's just think about these first 2 ones, because this is a typical case where those 2 things are mutually competing, in that if I want to maximize the number of patients attending a unit with 600 admissions per year, I want to have fewer units. I want to reduce the number of units, get rid of any small units that are there. But if I want to maximize the number of patients attending a unit within 30 minutes, I want to maximize the number of units I've got around the place. The more units I've got, probably the more percentage I can get within 30 minutes. So we've got conflicting objectives. Let me skip this slide, too many words. Let me just go straight onto it. So what we do is we optimize what's called a Pareto front. Now, Pareto fronts, you see here, aren't too hard to understand when you've got 2 objectives. They get a bit head bending when you've got kind of 8 objectives or whatever. But the Pareto front is that set of solutions where an improvement in one objective can only be achieved at the detriment to another objective. So, a common one might be, you want to minimize the weight of something but maximize the strength, and those 2 objectives are sort of mutually exclusive. And so here we've got some cases as we try and get higher on an objective A, we necessarily harm objective B. But there's this, so that we think of Pareto as also, it's the trade-off. It's kind of, we want to get in this corner here, but we can't, because as we adjust one, the other one falls. Or if we improve one, the other one falls. But we're interested in what's the best possible range of solutions here. And then that can be used to provoke more discussion about, okay, what trade-off are you willing to accept? But here is the trade-off. This is in two objectives, but we can do it in more objectives. So the formal way we say it is 4 points on the Pareto front. There is not another point that is better in at least one objective, and that is at least as good in all other objectives. So again, it's a case of if you're on the Pareto front, as you try to improve one thing, you'll hurt something else. And these, I'll mention this name here because it's going to come up in a second. We call these non-dominated points, these on the red line. and the other points are dominated. In those points, I can actually improve one of the objectives without harming the other one. So these are suboptimal, or what we call dominated points. It's a weird phrase, but it comes into the name of the algorithm we're going to use, which is NSGA2, non-dominated sorting genetic algorithm 2. What a mouthful. So NSGA2 selects its breeding population rather than having a fitness score, which you probably did for your genetic algorithm earlier in the week. It selects all of the points on the Pareto front. So it's always trying to find these points of optimal trade-off between the two or more objectives. And then if you find actually your selected population on the Pareto front is smaller than, you said you were going to maintain a breeding population of 500 solutions or whatever, what you then do is you take away the first Pareto front and you're left with a new Pareto front. So for example, here, if we removed all the points on the red line, then we could draw a new Pareto front, the points sort of coming a bit next in line below it. And so you can keep on selecting those that are either on the Pareto front or close to, until you've got enough. And then at some point you end up picking too many. So Elliot might have mentioned tournament or roulette selection, which is a way of sort of saying, okay, if I want to reduce the size, I'm going to say I'm going to pick two to fight each other, and those with in normal genetic algorithms, you say those with the highest fitness score, you might say, well, they've got an 80% chance of being selected. So sometimes you actually select a weaker one. In this case, we use tournament selection to thin out the crowd, if you like. So we say you're more likely to be picked if you've got a large distance to your nearest neighbor along the Pareto front. So it's just a way of thinning it out. Okay, that's the end of the description of the algorithm. So let's see some results of using it and see these trade-offs in action. So this is the number of stroke units up to 127. The grey dotted line at the top are the number of patients. Now, these are the best solutions we can find using our genetic algorithm. These are the number of patients who would attend a unit with at least 600 admissions per year if everyone went to their closest unit. And you can see we can get up to about 85 units, and then we start to hamper this objective. As we add in more units, we necessarily start to split some bigger units up so that patients will start to go to smaller units. The dashed dot line below that is the proportion of patients that are within 300 within 30 minutes. So not surprisingly, as you add more units, you can get more patients within 30 minutes, until we get to sort of 89. I think that's, sorry, earlier it just reminded me, I think I put 98% within 30 minutes. 89% currently within 30 minutes. So that's as high as we can get it when you're picking from the existing, and it's a sort of law of diminishing returns. It's it's steep at the start and then getting shallower. And then if we say want to combine these two objectives, what's the best we can do is the proportion of patients living within 30 minutes of 600 admissions, then we maximize that objective if that's really what we absolutely care about. And all these problems are more complex than that, but it gives a guide that we can get it to between 80-82%. We're using between 70 and say 100 units. And you can see here 100 units is also the where we're really getting very little gain in portion of patients within 30 minutes. So, and there are now actually 101 units that's not a direct result of our work. We just want people one lot of people that were feeding into all the discussions going on. And there'll probably be a little bit more consolidation of units as well, because there are still some units which are struggling a bit in size, and therefore having the expert staffing the whole time. So the genetic algorithms identified these, and it's identified the trade-off. So rather than a single optimal, we say, here's your trade-off. Where do you want to stick with it? And we can also start to say, so this is the patient's number within 30 minutes. This is the best we can do, this top line, if that's all we care about. But we might care about other objectives. So the question is, how much might interest in other objectives harm the get this objective? And the hashed area sort of shows we had about 8 objectives here we're optimizing on. Where with any particular number of units, what's the range of patients that would be within 30 minutes if we cared about other things as well? Similarly here, you know, the top line represents the proportion of patients within 30 minutes of 600 admissions per year, if that's really is our most important thing. But what might that drop to if we considered other things as important? And then we can show some example solutions, and we're always keen to say these are example solutions, and we produce a few for people to look at and talk about, rather than provide the computer says this is the single best solution. We actually had a population in the end of about, I don't know, 1,000 different solutions that could be discussed. You can rank them in some ways, but this is an example where we've said absolutely all the units must have at least 600 admissions. That's an objective. We find the largest unit has 1879 admissions, 80% of patients within 30 minutes, 95% within 45 minutes, average time 22 minutes. But you can see gaps here. If you absolutely insisted on 600 admissions, and the gaps tend to always be roughly in the same place, North Devon, Isle of Wight, and Cumbria. So, and you know, it's the more rural communities, but things like this start conversations about how many and where service should be provided. So just in summary, a lot of healthcare problems, we find location problems, are about solving or exploring at least competing priorities. You're often trying to achieve the benefit of scale or trying to get care as local to patients as possible. And the two are often, not always, but often, they often fight against each other. You can use brute force to calculate all possibilities up to about 20 locations to choose from. That's about 1 million possibilities to calculate, which, you know, is not too scary. But then it very quickly goes, you know, from you add 2 more and you're up to 4 million. And you add another couple more and you're up to 16 million. So this is where the scales get extreme. So that's where we use heuristic methods, and Pareto-based genetic algorithms provide a useful way of exploring those trade-offs. Because we wrote our own bespoke one because we wanted to do some very particular work on this, but there are libraries that have got Pareto front genetic algorithms in. The main one probably being DEAP as a whole is probably the go-to Python library for a big range of genetic algorithms, though I'm sure other libraries also exist. How's that for time, Dan? That's just about okay, isn't it?
Yeah, pretty much spot on. Thank you very much, Mike. Really interesting. Such a, I'd say, a really nice demonstration of the kind of the very theoretical stuff that Elliot was talking about on Tuesday afternoon, and seeing what that means in the real world. So yeah, really interesting. So we've got some time for questions. Does anybody have any questions for Mike? Stunned into silence. While people are thinking, I've got a question, Mike. So how do you find, because obviously, I mean, we've talked before about the fact that this stuff is it's pretty complicated. This is, I remember doing evolutionary algorithms in, sort of third year of my computer science degree, and it's quite complex stuff. How do you find that people, sort of stakeholders that you're working with, respond to this kind of stuff? Because obviously, the some of the methods we teach, things like discrete event simulation, you may not understand, somebody may not understand all the concepts about servers and generators and things like that, but they get the gist of, okay, yeah, it's sort of people queuing for resources, and I get the, but I guess because this one is this kind of approach is quite difficult to understand. How do you find that sort of people that you're working with respond to this, particularly when you're sort of giving them results that are something like this, where you're potentially sort of opening or closing units, and obviously they can be quite controversial decisions. So I'm imagining people want to sort of understand it a bit better, how you're coming to those kind of conclusions.
Yeah, it reminds me of the question. So David Spiegelhalder, who I remember, was asked once, how do you explain log odds ratios to the general public? And he said, you don't. So in a case like this, we wouldn't try and explain genetic algorithms. What we explain is that we're exploring the trade-off, the Pareto fronts, and people get that. People get that there is necessarily a trade-off between these different objectives, and so we don't try to describe NSGA2 in any particular depth or genetic algorithms. We just say we're exploring the trade-off. We also get that we generally have a clinician present this, which always helps as well.
Yeah, I think that's a really interesting point. I think something I think it's useful advice for coming to HSMA projects, because we've got all of you as the cohorts are learning about all this pretty complex stuff, and some of the stuff that we're teaching you in the program cutting edge, but not all of it will be easy to digest for non-experts. So I think remembering that's really, really important when you're conveying the results. And I think putting it in language that they can sort of understand. I think as you said, Mike, understanding trade-offs, that's something that they can all get, why those two things are competing and why there would be trade-off decisions that need to be made for that.
Yeah.
Thank you. Any other questions?
Yes, I've got one. As per usual. Thank you so much, Mike. That was really interesting. Super presentation.
Thank you.
I wanted to ask, how long did the whole project take, sort of start to finish, in terms of the analysts, and how many people actually worked on it?
Right, so that's a slightly complicated question to answer, because we actually developed these algorithms on another project for location and neonatal units, and then we applied it to this. I guess the bulk of this work probably took, say, 3 months of work on it. This is a big problem, even for genetic algorithms. We've got a huge number of solutions, and we also had actually 8 different objectives, and that they take time. I mean, one thing you can do, so this comes into the nuance of genetic algorithms. With things like this, you can always start off by optimizing your most important objectives first, and then introducing other ones later on to explore, but these algorithms could take a week to run, so that they are not rapid. Genetic algorithms are always, they're not, and this scale of problem, and so we'd have sort of it running on multiple CPU cores too. But I'd say the bulk of this would be 3 months of work of one person really knuckling down on it. And then the mapping as well.
Thank you.
Brilliant, thanks, Mike. Any other questions for me, please? No, in which case, thanks again to Mike for coming along today. As hopefully that's given you a bit of a insight into how some of this geographic modelling stuff can sort of pan out for really interesting and large-scale problems as well. So lots of food for thought, I think, for your projects, and geographic modelling approaches are always very popular in the HSMA programme. So it'd be interesting to see what comes out in terms of your project proposals. So we'll close off there, and just to flag up, as I'm sure you all know, after tomorrow I will be off for 2 weeks post my surgery, so I leave you in the very capable hands of Elliot, who's going to be taking you through the next 2 weeks of stuff. Next Tuesday, looking at continuing the geographic modelling, so looking at both QGIS and GeoPandas, and getting to have some hands-on fun with some maps, and that was great. And then the week after, we've got some introduction to network analysis, and then a special workshop that one of our colleagues, Alison, is holding, which hopefully will be really interesting for you. Brilliant. Thank you, everyone, for coming along today.
Thank you, Mike.
Bye-bye, everyone.
Bye.